Our nominated president, Dr. Sulaiman Almutairi, is available today, and he will give us a little introduction about the steps we went through for initiation of this, for establishment of this society.
Excellent.
السلام عليكم.
السلام ورحمة الله.
مرحبا بروف جمال، مرحبا بالحضور جميعا. كلمة قصيرة عن الجمعية وعن إنشائها. was established a few years ago in university, and it's a society with a corporation of different subspecialty, include urology, gynecology, physiotherapy, and colorectal, especially the one dealing with the anal incontinence and disease. We think this society will add education, research, and we will initiate very soon the Journal of Saudi Pelvic Floor Society.
Excellent.
I would like to welcome you in the first activity. It's an honor to have you, Prof. Jamal, as a first in this. Thank you.
Thank you.
Shukran, Dr. Sulaiman. I'm really honored to be the first speaker for your newly founded society. I'm really very excited about that. And I think there will be a lot of value to the participants, exchanging knowledge and progressing the field. But more important to the community and patients who are going to benefit a lot from this well-defined society. I wish you best of luck, and I will and I am very supportive, and please, contact me anytime with any questions. I'll be happy to help. Thank you again for inviting me. It's an honor.
It's an honor for us.
Thank you so much, Doctor. And a few words also from one of the nominated member of board of the society, and he's the chairman of the urogynecology department at King Fahd Medical City, Dr. Ashraf Dawood.
Ahlan, Dr. Ashraf.
Assalamu
alaikum. Welcome, Dr. Ghoniem, and thank you very much for accepting the invitation. For this new society, inshallah, we're hoping that to have and to encourage physicians to participate in clinical research. We all agree about the importance of clinical researches, and having our local data and compare it to international benchmarks will be an add on the society level, as well as to the benefit of the urogynecology and female pelvic medicine population. Again, thank you very much, and for accepting our invitation and being the speaker for tonight.
Thank you, Dr. Ashraf. Again, it's my honor. And I have always worked with urogynecologists, and I know many in Saudi Arabia who are really friends as well. And this is the way it should be. There should be multidisciplinary approach to pelvic floor disorders. And Dr. Badr knows that very well because he worked with me and trained in Cleveland Clinic. And firsthand, he witnessed how urology, urogynecology, colorectal integrated together. And again, that will benefit the whole team, but more important to me, the community and patients are going to benefit the most. But thank you for your invitation, and looking forward to participate with clinical research or any ideas we can exchange. I'll be happy to discuss it. Thank you.
Thank you so much, Dr. Ghoniem. And I think this new society will be a good gathering for all the specialties related to the field: urologist, urogynecologists, colorectal, physiotherapy, all work together. We'll have an annual conference that will be a big opportunity for everybody to meet the other subspecialty, to have presentation, to have knowledge also extended to the other subspecialties. We hope also to have education courses regular to everything related to the field, either in the field of voiding dysfunction or female urology, urogynecology, or colorectal, or even urodynamics. So I think we will face obstacles in the beginning for sure. It will not be easy. Start for sure slowly and grow up slowly. I will start now introducing our speaker tonight, Dr. Gamal Ghoniem. Of course, he's a well-known international expert in the field of female urology and reconstructive surgery and voiding dysfunction. Dr. Ghoniem, he did his started the journey in the United States by doing the residency at the University of Michigan, and then the fellowship in the field of female urology and reconstructive surgery, neurourology from Brown University. Currently, Dr. Ghoniem is professor and vice chair at University of California, Irvine Health School of Medicine, Department of Urology. And he's, of course, supervisor of many committees in the either AUA, SUFO, ICS, or IOGA, or AGS. So many international society. And it's our also pleasure to have him as honorary member of our newly founded society. So, Dr. Ghoniem.
Thank you, Dr. Bader, for your kind introduction. And again, I'm honored to be a member of the newly, or honorary member of the newly formed society. All what I can say, good luck. It's big work. And let me start right away because I can see about 90 patients online. So I'm going to share the screen with you and start into the lecture then. Can everyone see the screen now?
Yes, it's good.
Excellent. So, you know, I want to today talk about specific disease that relatively rare, but not as rare as you think. It's a female urethral stricture. And I want to update you on this disease. And actually, it could be a new thing we can look into it. So, of course, you know, urethral stricture in females will cause bladder outlet obstruction that is separate from sling obstruction, which could be a second part in talk. So, I want to advance, so we'll trouble to advance. For some reason, my screen, oh, okay, I'm here, okay. This is my disclosures. I'll start with the applied anatomy. Female urethra measures about 4 centimeters in adults and composed of two muscle coats, inner longitudinal layer and outer circular layer that actually thinned out as you go distally. The longitudinal layer is continuous with the detrusor muscle. The smooth muscle thins considerably toward the urethra, as I have mentioned. If you look into the cadaver, you can see here the urethra starting from bladder neck out to the external urethra here. And that green part here is the rhabdosphincter. This is striated sphincter that we talk about. These are the muscle disposition. As you can see, the mucosa lamina propria, and then this is the longitudinal coat, and this is the circular coat in the outside. Outside of this is the external sphincter or rhabdosphincter that's like a horseshoe configuration, very thick on the dorsum actually, and thinner on the anterior part of the urethra. So how are we can define the female urethral stricture disease? It's a fixed anatomical narrowing, and that exclude functional narrowing like neurogenic bladder with detrusor sphincter dyssynergy. Most of people would say, you know, 14 French is the lower limit that a caliber could be normal and does not lead to bladder outlet obstruction. So this is the definition that Smith put in, and I think it's a good definition till now. It's a fixed anatomical narrowing that does not accommodate 14 French without disruption of urethral mucosal lining. It does account for about 4 to 13% of bladder outlet obstruction in female. Etiology is right here, idiopathic, and that could include also childbirth. So if there is difficult labor, prolonged labor, with compression of the urethra on the symphysis pubis, and that would lead to devascularization and fibrosis and urethral stricture. Iatrogenic, needless to say, instrumentation, radiation, previous surgery, traumatic, rare in female that you have a urethral injury with pelvic fracture, but sometimes happen. I have only few cases actually in my career, and inflammatory or infection. Presentation, you have the classical bladder outlet obstruction symptoms of straining, poor flow, interrupted flow, incomplete sense of incomplete voiding, pain, and post-void dribbling. But also, if you have a long-standing bladder outlet obstruction, then you start to have OAB symptoms in the form of urgency, frequency, and sometimes also urge incontinence. Urinary tract infections could be related to this voiding dysfunction. And a lot of cases of urethral syndrome can be actually urethral stricture disease. When I say urethral syndrome, mainly urethral pain. So you have to have a high suspicion, high clinical suspicion in this scenario to look for other reasons of urethral pain. And on physical exam, easy, you can see meatal stenosis, lichen sclerosis, or atrophy. These are other things you look for. What are the diagnostic tools available to us? Uroflowmetry is non-invasive with bladder ultrasound is a very good start to see what's going on. But still, urethroscopy is important, urethral calibration, and urethrography. When I say urethrography, you don't do retrograde urethrogram in females. It's difficult, inconvenient, and less yielding. This is only the way to do it is VCUG or voiding cysturethogram. So there is no antegrade study in this scenario. Video urodynamics, that's my preferred because I do see like a VCUG, but also I can diagnose outlet obstruction. So both the dynamic part of it and the visual part of it can give me a good diagnosis. Not only good diagnosis, also the sites where this obstruction is. MRI, we'll talk about it a little bit, but it's not really the major one. Usually, we use 2 to 3 modalities to come to a final diagnosis. And most commonly, we do urethroscopy, calibration, and contrast study to find that. MRI just to rule out urethral diverticulum abscess or periurethral pathology causing obstruction. You may find some periurethral fibrosis, and also, but generally speaking, the diagnostic value is low, and we rarely use it in that scenario. So studies in healthy women, what about urethral calibration? Healthy women reported average calibers between 22 and 26 French, there was no correlation between urethral caliber and age. So in adult women, calibration between 22, I never really do 26, maximum 24 French. Other authors have suggested that a normal urethra should accommodate a 30 French sound comfortably. I think that's stretching actually, and you will find more of this with the old urologists and urogynecologists. So we don't use that overstretching of the urethra anymore, knowing that can lead itself to future fibrosis. So voiding cystourethropy may delineate the narrowed segment or demonstrate proximal urethral ballooning. And I'll show an example in a minute. Video urodynamics is highly desirable to exclude coexisting dysfunction as stress incontinence, detrusor overactivity, as well as providing estimation of the detrusor contractile function, which may impact the patient ability to empty their bladder postoperatively. So we used, in summary, we used video urodynamics for counseling the patient, for finding and verifying the stricture, verifying bladder outlet obstruction if there is, and also other conditions like stress urinary incontinence, which is important in counseling. You may add anti-incontinence procedure to your repair if needed to. Urethral dilatation, yes, it is used and still used in female urethral stricture disease. The best data available assessing the efficacy comes from a small study by Smith et al. Again, the diagnosis, as we said, 14 French, and he used this as the cut-off point. Used confirmation by urethroscopy or fluorourodynamics. A total of 7 patients underwent dilation using urethral sound to 30 French. So he did overstretch it. If you see here, it had a mean follow-up of 21 months. But more important here, this number, that 57 of patients did not require any further formal dilation. So there is a place for that. So if you have 10 patients, at least 5-6 patients will do fine after a simple procedure of dilation calibration. Like this case, I have a patient with T3 rectal carcinoma that have chemoradiation and developed urethral stricture. You can see here on the left side the stricture band here, and this is after dilation. Actually, this band kind of broken, so it led to a normal urethral caliber in here. This is what I use in the clinic. It's kind of Hagar, but they also have, they are hollow and they have like a metal catheter actually, and you go gradually with the dilation. So surgical reconstruction would be a definitive treatment for failed dilation or if the stricture is tight from the get-go. We use vaginal labial flaps, vaginal labial grafts, and oral mucosal grafts. Essentially, I want to say just two words about flaps and grafts. Flaps are pedicled and they have a good blood supply. So the outcome usually is very good. Graft is a piece of tissue that is transferred from one side to the other without pedicle. So it does depend on the surrounding structure for to live and to stay without scar tissue. You know, I myself, had a problem with doing buccal mucosal graft in radiated female urethra at Cleveland Clinic, and I was trying to reconstruct the urethra, and it ended up with stenosis and fibrosis. So these are very important to when you decide to see the local tissue condition, whether a graft would be suitable or not. I have to add, though, that the buccal mucosal grafts also have had some good success in female urethral stricture. So in reconstructive approaches, the surgical approach could be described relative to the position of the urethra. So if you're going dorsally, meaning above the urethra, that's 12 o'clock position. Ventrally, that's a vaginal part of it, like around 6 o'clock, or circumferential, that you dissect the whole urethra, which we really don't do. I don't know if someone is doing the whole circumferential. So let's stop for a minute and talk about ventral versus dorsal. Ventral definitely is easier to do, does not require a great deal of mobilization, and is familiar for us in female urology and urogynecology. We open and cut the vaginal wall all the time. But on the other hand, there is a great chance of causing urethrovaginal fistula. And also, I found, because I did both ways, I found some patient would have spraying of the urine flow or misdirection of the urine stream secondary to that approach. So if you're doing it, you have to be careful. Dorsal approach provides better mechanical support to any flap. So actually, if you do a VCG after dorsal approach, it looks like normal because it has good support dorsally. Also, having a well-vascularized bed, which is the cavernosal tissue. The major worry is the potential damaging of the sphincter or clitoral bodies, or the nerve going to the clitoris. I think, for me, that's not a major worry, because you know exactly where these nerves are. They run along the ischial-pubic ramus, and you have no business going that lateral. Same thing for the cavernosal bodies. You have really to stick to the area around the urethra. You may need to cut the pubourethral ligament a little bit, but that usually is no problem. Vaginal flap urethroplasty was first described by Harris for the treatment of urethrovaginal fistula. In the contemporary literature, flaps are the most common reconstructive techniques. So because of familiarity, as we said, flaps are particularly advantageous because of their mobility and good vascularity, and they can be raised with relative ease. Most commonly, flaps are advanced as inlay, either U-shaped or C-shaped. You can do a lateral flap like Orandi flap, and there is a 91% success rate, which is pretty good in one study with a follow-up of 32 months. The technique can be utilized if it's not possible to mobilize adequate flap. A success rate of 80%, and this labeled in the graphs, follow-up 22 months, was reported in 4 studies. Oral mucosal graft is particularly useful where vaginal epithelium is atrophic or fibrotic, so it's undesirable for a flap interposition. But again, as I said in my case, be careful about the local tissue condition when you do a graft. In a systematic review of literature, a success rate of 94% with a good follow-up actually was reported. So I think it's a good thing to consider and to put into your armamentarium. Let me present to you a case, and then after that we can even take questions. Yeah, a case of mine, 33 years old, female, parity 3, gravida 3. Present to the clinic for evaluation of obstructive urinary classic symptoms since 2008. Following a complicated normal vaginal delivery, so this is another etiology here is there. A history of obstructed prolonged labor and vacuum-assisted delivery. She have recurrent episodes of urinary retention, weak stream, with difficulty emptying, needing to strain to void. Urinary tract infections recurrent 7 to 8 times a year. Patient also reported difficulty with insertion of a Foley catheter. She denied any neurological disease, no gross abnormality noted, and has normal bowel function. Previous treatment in outside facility, since 2009, frequent urethral dilation, cystoscopies, like almost every 3 to 6 months. Patient stated that her urination improved after the dilation, but her symptoms would get worse 2 to 4 months later. Patient has tried, as usual, tamsulosin, pelvic floor muscle therapy, Botox injection to the pelvic floor, and she reported minimal or no improvement after each of these treatments. On physical exams, vital signs are normal. Her weight is 52 kilograms and the reasonable body mass index of 22. Other examination, pelvic examination was normal. In the clinic, I do flexible cystoscopy on the females, which is about 16.4 French, showed normal distal urethra, and was able to advance only 2 centimeters from the external meatus. And then I saw the narrowing that could not pass the flexible scope into the bladder. Underwent fluorourodynamics, and this graph here, let me see if I can show that better. So you see here in the first line here, this is the vesical pressure, this is abdominal pressure, but what we look for is this the detrusor pressure, and this is the EMG. This is the flow. So forget about the other urethral pressure and so on. So let's just concentrate on that area here. As you can see that the patient start voiding with no flow for a few seconds till finally, and EMG was pretty good, silent almost, and finally starts to open up, and the flow started here and almost interrupted, some spasm here of the external sphincter and prolonged it. So you can see flattened flow, almost interrupted, and prolonged voiding time with low peak pressure and high detrusor pressure, as you can see here, 81. So that was diagnostic, but also more important, the picture that was with that also showed where is the obstruction. And as you can see here on this, uh, uh, if you want to call it VCG, but actually it is from the study, you can see you never see a bladder neck open that much in female. And this is ballooning of the urethra above the level of obstruction. And the external meatus is here. So this is a mid-urethral stricture, and this is very graphic demonstration where it is. So I did a dorsal approach or 12 o'clock approach, and we did that here. You can see I put a tiny catheter in, a feeding tube in, and this was my incision, semicircular incision in here. You can see I'm holding the urethra with a DBK, non-crushing, and cutting around the urethra in here. So this is advancing dorsally, and I put two-stage suture on the external meatus and went further to mobilize the urethra here. So the ventral surface stayed in there, the vaginal surface, in other words. We did not disrupt that. As you can see here, the stricture, you see the scar tissue here, and this is the knife actually that we're cutting it in the middle. And after that, after cutting it, a rule of thumb, you use 20 French catheter to build your urethra around it. You don't have to do 24 or 26. 20 French in female is good. So I used the red rubber catheter, 20 French in there. I moved a flap from the labia, actually, minora, because it's very smooth surface and have a good pedicle. You see the pedicle here. And advanced this flap to go above the urethra, as you can see, and then closed everything. Patient did well postoperatively with no problems. So there are some good advantage of this. Achieve a more natural urinary stream by avoiding a hypospadic meatus. So that bothered a lot of females. They had a good flow. They are no obstructive symptom. The issue is solved regarding obstruction, but you treated this with another problem, which is spraying of the stream or even misdirection of the stream. Definitely, there is reduced risk of urethrovaginal fistula. Problem with it, you have to be very familiar with the anatomy. The section close to the neurovascular bundle may lead to sexual dysfunction and may injure external urethral sphincter. At least this is a theoretical consideration. But it really doesn't happen. I found a very recent abstract. This is from the European Urology 20 Virtual Congress, since, with this COVID epidemic and everything, from India. And what they did, actually, let me go back a little bit. Yeah. They found no difference in outcome between ventral and dorsal only graft urethroplasty, which is interesting. They measured urine flow rate and did urodynamics and symptom score. However, they did not report on other problems like the misdirection of the stream. Would have been interesting to do the discussion with them, but I didn't have a chance to do that. So key points: female urethral stricture is a rare clinical entity that lacks a clear definition. At least today we discussed and try and find some more definition. In patients who are fit and willing, serious consideration should be given to reconstructive procedure if a second dilation is unsuccessful. That's a conservative approach and reasonable approach. Especially the reconstruction results in the 90s, between 85 and 94% success rate. Majority of studies continue to support established evidence that urethroplasty in FUSD is potentially very successful. And I want to share that with you, that the incidence of stress urinary incontinence after surgery is extremely low. So I don't think you should be shy of doing it if you have a good indication. Other potential problem damage the clitorocavernosal tissue was not formally addressed by assessment of sexual function. So it would be nice to run a study, multi-center study, using female sexual dysfunction questionnaire in addition to other parameters, but that could be a very good addition to the literature. If the society have enough surgeons doing it in different parts of Saudi Arabia, and you just have a simple protocol with a questionnaire, that would be something very good to consider. Available evidence suggests that the experienced hand success is about 100%, approaching 100%. There's not enough evidence to recommend one technique or approach to urethroplasty over the other. So really depends on your choice and comfort and surgical training. Risk of stress urinary incontinence is low after urethroplasty. So in conclusion, urethral reconstruction is recommended in patients whom stricture disease recur after 2 urethral dilations. Urethral reconstruction should be performed in specialized centers. In patients unfit to undergo surgery or who decline surgical treatment, palliative self-dilation is a reasonable option. There is a need to reach standardized definition and diagnostic criteria to improve compatibility between studies. And I think the Society of Urodynamics is trying to do that these days. So at the end, you know, unfortunately or fortunately, ICS is going on online now. I'm the chairman still of that meeting. Will be between 4 days in November 19 to 22. And I invite you all to register. It will be very good conference because you can reach abstracts and presenters, workshops, you can reach them. But more important, it will be pre-recorded at any time. You can go back and listen to a lecture or discussion in that. Thank you very much.
Thank you so much, Dr. Ghoniem. Very informative presentation. And we need to learn from an expert like you because I know it's very tough, a lot of controversy there. So we're glad to hear from you today as an expert in this special topic. I have a question about the practicing the urethral dilation. You know,
Yes.
in the old practice, old urology practice before the subspecialization, there was practice of doing urethral dilation for almost every woman complain of difficulty voiding.
Yeah.
So unfortunately, some of the general urologists may be still practicing this until now. So to avoid this, what do you think the minimum criteria to label a woman as having urethral stricture? Do we need to do VUDs for every patient or cystoscopy is enough to confirm? Or
yeah, It's a really excellent question, and it's a real problem. And as I said, I had a long time ago when I was a professor at Tulane, I had a discussion of one of the older urologists, and he was dilating every woman, and he was very aggressively dilating them, like 32 French. So I said, why you're doing this? And he was doing it for any urethral pain, for recurrent urinary tract infection, for urethral stricture, almost indiscriminate. Why you're doing all this? He said, listen, I have a great results. When I do the dilation, I never see the women back. I said, yes, because they are afraid from you. It's so painful. That's why you don't see them back. So back to your question, yes, I try to be very specific about indication and doing at least studies like urine flow, post-void residual. These are non-invasive, and maybe urethral dilation. I mean urethral calibration, sorry. So if I find the resistance at 14, 16 French, I stop right away. Patient will tell you. And then you can do urethrostomy, you can add video dynamics. That's a good question. If you intend to do reconstructive surgery, repair, I think it's a good idea, and it is recommended to do some imaging, either VCG or video urodynamics. If you are going to go dilation, which we said about 60% of patients would benefit from that, then you might not need to do even urodynamics. So if you have a good diagnosis already and you go ahead and do dilation, you can serve a lot of female. But if they come back after a second dilation, then I consider seriously, I wouldn't waste time. The usual story, and probably all of you know, that the patients will have benefit like 6 months and so on, and then the time between dilation shortens, and then it becomes to be really ridiculous, like every month or every 2 months, like my patient, which is really not a good way to run a life, like that. So definitely, I would say 2 dilations are enough. Thank you for that question.
Thank you. Dr. Ashraf maybe has a comment.
Thank you. Thank you very much, Dr. Ghoniem, for your very nice presentation and simple explanation of a very complicated and complex disorder in female and in voiding dysfunction. I was just going quickly through the questions, and some of them was also in my mind. Any particular specific or preferable protocol during dilatation that you use, like local gel, local anesthetic, or doing it under sedation for different patients, like some of them, the intolerability of the pain, difficult positioning, and sometimes due to orthopedic disorder. What is your approach for this, and if you have any tips and tricks?
Yeah, I first of all, I do urine analysis, make sure they don't have UTI. I start antibiotics the day before. I give them oral relaxing medication like Xanax and some light pain medication, and ask them to bring someone with them to drive them back home. Then I do instill Urojet or lidocaine 2% into the urethra. It would be better if you have it in the fridge. That's the trick, if you can. So it's a chilled lidocaine jelly, 2%, and really be patient. You have to be about 10-15 minutes before you do the dilation. then it will be fine. You know, I didn't have any problem with patients complaining, and the level of pain, they will feel something, they will feel some discomfort, but not really pain. But I mean, that's my protocol. I continue antibiotic for another day after the procedure, so total is 3 days. So when I decide to do it, they go with prescription of antibiotic, Xanax, and hydrocodone or Tylenol number 3, and I made sure the urine is negative.
Thank you very much.
Thank you. Maybe Sulaiman, you have any comment?
Thank you, Prof, for this nice lecture. I have 2 questions actually. The first one is, what is the role of tamsulosin in female obstruction in general?
Dr. Sulaiman, I didn't hear what's the role of what?
Tamsulosin.
Tamsulosin.
Well, again, you know, I tried to get away from not fixed urethral stricture. So in primary bladder neck obstruction, like males, it's usually more in males, you know, tamsulosin works well. And sometimes I use it with pelvic floor dysfunction in female also. And usually the calibration is negative. Then I use tamsulosin. It's okay to use it in that situation. So I don't use it at all in urethral stricture. So after negative calibration, they have obstructive symptoms. So they have a pelvic floor dysfunction or neurogenic bladder. And in this case, yeah, I use physiotherapy and also alpha blockers like tamsulosin, yes.
My second question is about the symptom of when do you expect stricture in female? Because the symptom is overlapping, urgency, when you go for cystoscopy.
Yeah, any bladder outlet obstruction, either male or female, eventually they get overactive bladder symptoms. But the story will be telling, so you have to go back and tell them which started first. You know, were you having problem emptying? Was it you know, were you pushing or straining before this urgency frequency came by? And again, you know, that's the value of doing urodynamics in this case.
Okay, thank you.
We have Dr. Muhammad Lutfi. He has a question.
Yes, Dr. Muhammad.
Dr. Muhammad, you hear us?
I will ask a question until Dr. Muhammad come back, if you allow me.
Okay, sure.
Yes.
Of course.
Is there any rule for laser incision? Is it helpful in the scarred urethra of the female?
It's a good thought. It will be like DVIU also, but you know, I don't see a big advantage over direct visual urethrotomy or over even dilation itself. But you know, there is no really studies to show a good outcome with that.
And regarding the dilatation, what is the time between each dilatation usually? If you want to do it, is it like 1 month, 3 months apart?
Yeah, usually if I go that route, about 3 to 6 months after the initial dilation. Yeah.
Yes, Dr. Muhammad, you are with us?
Yes, yes, I am with you.
Can you,
Do you hear me?
Yes, introduce yourself.
Yes, I'm Dr. Mohammed Lutfi Mahrousa from Germany. I am working in Kuwait, and I would like to ask you: are you with me to try in recurrent urethral stricture to use the intraurethral ultrasound to see the surroundings of the urethra if there is any periurethral fibrosis, which could be the main cause and not the mucosa itself. So we can remove the fibrosis around the urethra, and this would be a good solution maybe for the periurethral fibrosis instead of dilating or cutting the urethra intramucosally without removing the fibrosis.
Yeah, a very good question. In my hands, I really don't have any experience with intraurethral ultrasonography. But when I suspect periurethral fibrosis, I do MRI, Tesla 3 or higher. And if you have a good radiologist doing MRI, you can pick up a lot of stuff with that. And that could be a good guide, as you said, you know, if it's extensive fibrosis, then you don't waste your time doing too many of these urethral dilation. You can go ahead for repair. Also, we can roll out other pathology like urethral diverticulum, abscess, or any surrounding compression of the urethra by doing MRI. So I'm more comfortable using MRI, but you know, the intraurethral ultrasound is a good idea, but I don't know how thin the probe would be. If there is a stricture, can you pass it through? And to me, I don't have any experience. But thank you for this question. Marhaban bik, Dr. Muhammad from Kuwait.
Thank you very much indeed.
So any other questions from the attendees? Or we can ask a question here. So Dr. Ghoniem, before starting the first dilation, do you take it just as calibration is enough, or you have really to see something like fibrosis or real reference?
Yeah, the minimum, you know, in addition to history and physical exam, urine analysis, uroflow, and post-void residual by ultrasound. If I am comfortable and suspecting stricture, then I do the calibration and possible dilation at the same time. So that would be the first one to do, and see the response and how long it will take. If it comes back, then I'll do urethrostomy and video urodynamics and start to give the patient the idea about doing reconstructive surgery.
But I think also we have to keep in mind that also voiding dysfunction is more common than urethral stricture disease. Or if we say the sphincter issues, the DSD, dysfunctional voiders, the other things for the bladder outlet obstructions is more common than the urethral stricture. It accounts only for 8% of the voiding dysfunction.
Yeah, I agree totally with you. But you know, if you are not aware of urethral stricture disease in females, you could miss it as well. But
Yes.
as a specialized society, you know, from bladder outlet obstruction in female, about 10% female urethral stricture, then we have really to be aware of it. And that's really the idea of this talk today.
Yes. So any other questions from the other panelists?
Yeah, actually, there is two questions from Dr. Asara Hassan. What is your target peak flow in these patients?
Usually females void by very low pressure, maybe 10, 15, and a high flow. It depends on the volume. So if the peak flow is less than 17, then with a good volume, like above 200, then I suspect something is not right, whether pelvic floor dysfunction or stricture, if it's going this way.
The second question is would you consider anti-grade incision through SBC and flexible scope with laser from inside?
I didn't get the whole question. To do laser from inside?
Anti-grade, yeah, through SBC, through suprapubic.
No, I don't. You know, I mean, the urethra is right there, so why go suprapubic and then traversing the bladder neck and coming down? I mean, you can, but it's too much for what you want to do. You can do it through the meatus if you want, and you can try the laser, whether green light or holmium laser. Both of them can work in this case.
Last question, with the dilatation, is there any rule for local estrogen?
For local?
Yeah, estrogen, local hormonal treatment.
Oh. Yeah, when this urethral stricture disease happened on postmenopausal women with vaginal atrophy, definitely local hormonal treatment will be very helpful. It will be depending on your physical examination, whether this is moderate or severe vaginal atrophy. I use conjugated estrogen cream. I use it 1 gram twice a week, but maybe initially even more than that, like every day for 2 weeks, and then drop down to twice a week, 1 gram. And studies showed that this is not really carcinogenic in nature, because we always worry about that, especially if the patient have any history of cancer, breast or uterus or cervical cancer. Then we have to be careful.
Thank you, bro. Thank you for answering the question.
Do you have, from your experience, the cases you did, what's the percentage they recover the overactive bladder, recover after relieving the obstruction?
Yeah, it's an excellent question, and I always counsel my patients on that. The longer the obstruction, the longer the recovery. So they still have urinary frequency urgency, and even sometimes I tell them you might have urgent incontinence after the surgery because I will remove the blockage and your bladder is still overactive. So, but in this case, if I remove the obstruction, I put them on medical therapy for overactive bladder. It takes few months sometimes. If it's a recent obstruction, usually a few weeks, but you know, have to be patient with these patients and start them on anticholinergic or beta-3 agonist for maybe 3 to 6 months.
And I know the stress incontinence is rare after the urethroplasty, but what if it happened? Do we use TOT, TVT? Is the urethra will be suitable for that?
Yeah, again, you know, stress incontinence with urethral stricture disease can be found, especially if the etiology is the same. But you have to diagnose that prior to the procedure. So if there is, then you can do, it's safer to do a dorsal approach, urethroplasty, whether graft or pedicle, a flap, and then you can do a TOT at the same time. So you are away from the site of the repair, leaving the catheter in. I leave urethral. I don't even put suprapubic. 2 to 3 weeks after that.
Yes.
Yeah. But,
okay.
you know, again, I want to stress out that stress urinary incontinence in a normal woman with female urethral stricture is rare to happen. So if you end up with fixed urethra, probably some bulking agent would be enough.
Would be fine, yes. Is there any relation between urethral stricture disease and sexual dysfunction in ladies? This is a question from Mishal Zahrani.
Yeah, not that I know, but this is unexplored area again. That need some enthusiastic female urology, urogynecology to look into it. It's not really explored. Yeah. So it would be interesting to have the female sexual dysfunction questionnaire before and after such a procedure.
Yes. Okay, so I think no more questions. Thank you so much, Dr. Ghoniem. We learned
You're welcome.
It was very nice presentations, and then the questions also from the attendees were good and to the point. We know it's very complicated topic, but we learned a lot about it today.
Yeah, excellent, and thank you. Good luck with the new society. I want to thank all the audience and their participation, and definitely the questions reflect the good understanding of this issue. Thank you.
Thank you so much.
Thank you.
Thank you.
You're welcome. Thank you.
Looking forward for the second part, which will be about the post-sling obstruction.
Yes.
Yes.
We'll do that. Probably in 2 to 3 weeks, I will correspond with the society and decide on a good date for all of us.
Yes. Thank you so much.
Thank you.
See you again.
Good luck.